Dun da da, Fink and Friends. Da, 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 da. Good afternoon, America and worldwide, if I may be so bold. My name is Dr. Randy Fink, and it is that time again. It is 4 o'clock in the mountains, 6 on the east, 3 in the west, and 5 in the central. That's right. Fertility with Fink and Friends, live from Colorado Springs. Good afternoon or evening, as the case may be. It's great to see everybody like we are every Tuesday evening at this time. What a pleasure to see all my old friends joining in here. Sharmilla, welcome. J.M. Dots, hey to Brandis, our wonderful nurse practitioner here, equestrian, and my wonderful mother and father in Mobile, Alabama, where I got to spend a fabulous past several days down on the Gulf Coast. Our thoughts go out to all those on the Gulf who are actually really on the west side of Florida, who are facing down the impending hurricane, have a storm blowing in. It becomes a way of life when you live there, but it never really gets any easier. So our thoughts definitely go out to all you folks there. Hey to Michelle Marks, Ryan, Angela. Thank you. Yes, we will talk about that, Miss Angela. Hello, Mrs. Vince. Nice to see you guys. We've got a bunch of people who are pregnant on here, which is always great to see. On the Facebook and YouTube and LinkedIn side, I see Jeanette is there. Also, a pregnancy-related question we'll get to, and right here on CNY's website. Lee Chio, nice to see you. I'm going to mess up the name. Hey, Rosa, always good to see you. Rosa SD, you are the first one to join every single week. Whoopsie daisy, good to see you. Oh, 6 o'clock in Aruba. So forgive me for not talking about Aruba time. Aruba is a lovely, lovely place. My journey with IVF. Hey, his question there, is it possible to fly in and out on the same day for an embryo transfer? I generally don't recommend that people fly in, try to get here on that day because, air travel has, unless you're flying private jet, air travel has really become so unreliable that it's hard to know for sure that you're going to get here in time. And, if there's a delay, if you're caught someplace, if, there's a mechanical or somebody has a flat tire, I was thinking about this actually since I did some traveling over the weekend, again, to see my folks in Alabama. How many airplanes are in the sky, and that's an amazing factor. But any one commercial aircraft, the number of highly complex systems that are required to get that aircraft to operate, and you imagine the number of things that can go wrong just to create the simplest little problem, like a light starts to blink when it's not supposed to be blinking, or it turns red when it should be green, is enough to say, you know what, I wouldn't want to travel on the morning of a procedure just because there's too much stress involved. Am I actually really going to be able to get there? So I would say get in the day before, and then you can leave afterwards for sure. You don't have to be on. In fact, we don't want you on bed rest after an embryo transfer. So I think it's fine to go home after that. Let's see. Hey to Jessica. Nice to see you. McHenry 93. Faith Houston. Good to see you as always. Oh, my Glenda. Good afternoon to you. How Fernandez, good to have you with us here. Hey, it's so nice always to be around. I do want to answer an important question that was asked by a dear friend here, and that is, what are Braxton Hicks contractions? And that has to do with pregnancy. Braxton Hicks, and every time you say it, you actually do have to pay a royalty to Doctors Braxton and Hicks. Just kidding on that part. I don't actually know who Braxton and Hicks were, and I probably could look it up, but they're practice contractions. They are fake contractions that aren't doing what labor contractions are designed to do. What are labor contractions designed to do? Labor is defined as uterine contractions that cause cervical change. So contractions are when the uterus itself starts to squeeze, and that's really what it's there for. It's designed to squeeze a baby out. But until it figures out how it's supposed to do that, it does a little here and it does a little there, it does a little practice here, it does a little bit of this and a little bit of that. So it's not uncommon that when you're pregnant, you feel practice contractions, and that's what are known as Braxton Hicks contractions. They can start in the second trimester. Braxton Hicks contractions we typically don't feel in the first trimester. We would just call that cramping. But in the second trimester, not uncommon, and certainly becomes more common as we approach term in the third trimester. So when is it not normal? Well, that's a good question too. And the problem is that if you call your medical provider, your OB on the phone, and you say, I think I'm having contractions. If I'm the receiver of that phone call, I'm going to say, well, I don't know what's going on. I can't examine you over the telephone. I don't know what's happening. Are these contractions, are they preterm labor? Or is it just little practice contractions? And I'd say, you probably have to go into the hospital, get checked. And then when you go in the hospital, it becomes this whole big, to do. It makes you feel like, gosh, you were pulling a false alarm, or you get scared. And, so here's my recommendation when it comes to practice contractions. One of the more common things that can cause the uterus to have these practice contractions is dehydration. So when you are dehydrated, your pituitary gland produces a hormone that causes you to want to retain water, to not diurese. It's called antidiuretic hormone, or ADH. And when it's doing that, that's also a similar function to the hormone, comes from a similar place as the hormone that causes you to have contractions, and that is oxytocin. So when you are dry, you tend to contract more. And that's why, when I was practicing in South Florida, very common for people to be dehydrated all the time. Consume liquid, drink, water, get that water down. A lot of times when you hydrate yourself better, those contractions will stop. What's another thing that causes those practice contractions? If your bladder is full. If you have a full bladder, remember the bladder sits right under, or actually right over top of the uterus. And so when the bladder is full, it's going to irritate the uterus and make it start to have contractions. So second thing, drink, but pee. You really want to try to keep your bladder empty. If the contractions are coming with some frequency after that, and they're not stopping, then maybe that's the time to go get checked out. But I think nice, reasonable, easy things to do to try to quiet things down. Hydrate yourself, and make sure that your bladder is empty. Now, there's some other things that can cause it too. If you're constipated, if you're on your feet all day long, that can make you more likely to, kind of experience some of those contractions. And a lot of people will feel them more commonly actually at night, because when you're lying down and you're in bed and everything is suddenly kind of, the rest of the world has gotten quiet and all you have to focus on is what's going on in your body, you may really be able to feel those more commonly. So hopefully that is helpful. Mrs. Vince has a beautiful baby at home, and you know what? I need to share a picture of Mrs. Vince's beautiful baby. Congratulations again. JM Dots, do you guys do consults for Canadian patients? Yes, absolutely. Absolutely, we do. Let's see. Stephanie Diana says, thoughts on a 6AA euploid embryo. I've heard good and bad on a 6AA. Well, so here's the question that you're really asking. That's a very highly graded embryo. It's a grade 6 and it's a double A. The two letters refer to different features of your embryo. One feature is what we call the inner cell mass, the portion that will become the baby. The other feature, the second letter, has to do with the trophectoderm, which is the outer part of the embryo, and that's the part that's going to become the placenta. AA is the best you can do on that, on an embryo grading kind of situation. The number 6 is really where I think your question lies. A grade 6 embryo means that embryo is fully hatched And think about a little chicken egg. That chicken has to come out of the shell. Same thing will happen ultimately as that embryo tries to implant in you. There's some people who feel like if an embryo is fully hatched, that the shell has completely come off, then that makes the embryo more fragile. Um, the truth of the matter there is that once, Stephanie, you have a euploid embryo, which is a chromosomally normal, tested chromosomally normal embryo, your odds of conception with that embryo are the highest we can offer in IVF, no matter what the grade of the embryo is. So whether that's a 4, a 5, or a 6, that 6AA embryo, the fact that it's a double A doesn't even change things there. It makes it a good graded embryo. It's a very pretty embryo. The fact that it's a euploid embryo means it's a 65% probability of pregnancy, irrespective of what that embryo grade is. So the euploid makes more importance, has more importance than does the grade of the embryo. Hopefully that's helpful there. Let's see what else we got going on the CNY here side of things. We've had a nice couple of busier days over here in Colorado, and it was nice and chilly outside. So when I was on the Gulf Coast, it was about 85, 90 degrees, got a little sunburn, as you may be able to tell. In my world, I call that tan, but the rest of the world would call that sunburn. And I came back here, it was about 50 degrees in Colorado. So, kind of a nice change. Feels like autumn is coming, and this is a fun time to be thinking about decorating for Halloween, and more importantly, celebrating my birthday, which is on October the 4th. And I'm sure you will all be. I should ask, what are you guys going to be doing to celebrate my birthday? Will you be having a special dinner, or planting some special flower? Maybe. I'm sure you all do special things to celebrate October the 4th, and I, of course, appreciate that. Rosa says, is Orlissa is Orlissa able to suppress deep and advanced endometriosis and ovarian endometriomas just enough for the FET to work, or does it only work on mild? I think we've talked about that before. It is sufficient to suppress any endometriosis as it pertains to an embryo transfer. Because when it comes time for embryo transfer, the only part of the endometriosis we really want to worry about is the part that is affecting the endometrium, the part that's affecting the uterine lining. And we know that what happens in that uterine lining is that you create an inflammatory effect, and that's brought about by a marker that's known as BCL6. We can test for BCL6. That's what the Receptiva test is for. And if you're positive, that means your embryo doesn't want to implant, and it's very easy to suppress that with 60 days of medication. So irrespective of how significant the endometriosis is and the rest of the pelvis, 60 days has been shown sufficient in the general population to suppress the inflammatory marker, the BCL6, in the uterine lining. And that's the part that you need to implant the embryo. So it's probably not going to make a big difference. 60 days is not enough to make a big difference in terms of how your embryo is, or rather how your endometriosis is behaving in the body. It's not going to shrink an endometrioma in the ovaries. It probably won't have a lasting effect on endometriosis pain. But what it does do is suppress the inflammation in the endometrium so that the embryo can implant. And really, that's all we want, because once you get pregnant, Rosa, you're going to be pregnant for, 40 weeks is 10 months. You're going to have a baby. Maybe you're going to breastfeed. If not, then, it's going to be several months before you go back to kind of having regular periods anyway. So you are going to continue to suppress the endometriosis as a result of the pregnancy. And hopefully it happens to such a significance as that then afterwards you don't have to deal with endometriosis anymore. It works that way a lot of the time. But the amount of endometriosis you have in your body doesn't matter as it pertains to suppressing the inflammation in the uterine lining for embryo transfer. Let's say hi to our friends over here on the Instagram, YouTube, LinkedIn side. Jeanette says, Jeanette Santiago, I'm currently 9 weeks pregnant thanks to CNY Fertility. That is fabulous, Jeanette. God, we love to hear that. My husband and I truly appreciate the helping and for being affordable. I have a question. I will soon be off progesterone and oil at 10 weeks, and I'm scared of stopping and the placenta not being ready to take over. Can I keep going until the first trimester is over? Will it harm the baby if I stop at 12 to 13 weeks instead? It's a good question. It's a question that we hear a lot. So, metabolically speaking, the placenta itself takes over the production of progesterone when you are about 9 weeks pregnant. So we continue that till about 10 weeks. If you wanted to continue through 12 weeks through the first trimester, you certainly can. No, it will not harm anything. But maybe one other choice you might consider making is maybe you want to continue vaginal progesterone. Because the progesterone in oil is no fun. It's a big shot that goes in your butt, and nobody likes that. The vaginal progesterone doesn't contribute to the overall hormone levels that we would check in your blood, but there's a local effect at the lining of the uterus where the baby is growing. And so that may be another thing for you to consider. Consider staying on the progesterone vaginally through 12 weeks instead of the PIO. But is there harm to staying on PIO through 12 weeks? Not other than what it's doing to your butt muscle to have to get an intramuscular injection every day, and the fact that whoever's giving you that shot probably has to chase you around the house, and it becomes very dramatic, and the news cameras are there, and all the rest of that stuff. So hopefully helpful there, Jeanette, and congratulations. All the best. And by the way, I'm assuming that you have looked with the ultrasound and that you have seen the heartbeat. Once we look and we see the heartbeat, we know that 95% of those pregnancies will continue on without having a problem. So the best odds in your favor are doing that ultrasound and seeing your baby's heartbeat. It would be very rare that there would be a situation that at 10 weeks the placenta wasn't making enough progesterone. So God bless. Dixie is here, a new patient soaking up some knowledge. Thank you for doing this. Well, Dixie, love the name. That's awesome. Callie Khrushchenk is here. And hey, Dr. Fink, what do you recommend? I had 3 natural miscarriages before doing IVF. I had a polyp removed and was treated for endometritis. I had 1 failed euploid transfer and 1 miscarriage with a euploid embryo 2 weeks ago. No known autoimmune issues, and was on the Immune 3 protocol. When can I transfer again? What should I look at testing wise? Any advice? Okay, so there are a bunch of miscarriages there. Then you had a polypectomy. You had 1 unsuccessful euploid transfer, and then a miscarriage from a euploid. So first thing I would want to know, so that does not sound like an endometriosis related problem, because endometriosis more commonly will stop the embryo from implanting rather than having the embryo implant and start to grow. Recurrent pregnancy loss is one of the most frustrating problems that we deal with in obstetrics and gynecology, in the fertility world. And of course, even for any couple having to deal with losing recurrent pregnancies is maddening, because every single day that goes by, you worry, what's happening next? What is happening inside me? I got that positive pregnancy test, and now it feels like everything is out of my control. And that's probably one of the most significant reasons that we as humans become uncomfortable with the idea of pregnancy, because it's doing its thing no matter what we do or try not to do. That we can't directly affect so much of what's going on inside. It's a very, very frustrating kind of problem, especially when you've had a history of things not working out as well as you would have hoped. So there's a couple of thoughts that I have there, Callie. One is I would certainly want to know that your uterine cavity is normal. So that would be number one, a hysteroscopy. I'd want to put a camera inside and take a look, make sure that there's no scar tissue, make sure there's not a septum, a band of muscle, make sure that there's not anything else mechanically going on. So you had that polyp before, which was removed, and I presume that was done through the hysteroscopy. So got a good thing going on there. Secondly, I would want to know that you don't have a condition in your body that's causing the blood to clot in the small vessels that are supplying the placenta. And that's what's known as a thrombophilia. A thrombophilia, thrombo means clot, philia means likes to, that there's something about your body that likes to clot. There's a set of blood tests that we do for that. There are several of them there. The two most common three most common are one that's called a lupus anticoagulant. It doesn't mean anything about having or not having lupus, but a lupus anticoagulant is one of those blood tests. Second is called an anticardiolipin antibody. And the third most common is called factor V Leiden. And these are things that we can test for in the blood. And Kelly, you certainly should have been tested for that by this point. If not, I would want you to do what we call our RPL panel, recurrent pregnancy loss panel. We don't do that when you're pregnant or when you have still have a positive pregnancy test after a miscarriage, because that can the pregnancy hormone can affect some of the levels of what we test there. So, and then the third thing I would think of would be from an immune standpoint. I would want you to use the medication that's called Prograf or tacrolimus. And we've talked about this before, so please forgive me if this is repetitive information for you. But tacrolimus is a drug that's used for folks who have had kidney transplants. And other types of organ transplants. And what it does is that it prevents the body from rejecting the donor organ. Well, the pregnancy itself, the body may be perceiving as a donor organ. It may be perceiving it as an invader. And so we mount a specific immune response against the pregnancy that can be mitigated by that medication tacrolimus. Now, at CNY, we have always used that drug as part of our level 3 immune protocol. All right. But previously, we were using it at a dose of 0.5 milligrams twice a day, which totals 1 milligram daily. What we know now from the evidence is that the correct dose is 3 milligrams daily. So in the big study, that was 1.5 milligrams twice a day. Problem is, tacrolimus comes in a 0.5 and it comes in a 1. It also comes in a 5, I believe. But in a 0.5 and a 1, it means that you have to fill 2 different bottles of pills in order to take one of each of those twice a day. The other alternative is you can just get the 1 milligram pill, I believe it's a capsule, and take it 3 times a day. So 100%, that's what I would do. We have added that to our routine protocols for folks doing embryo transfers here in Colorado. And what we have seen is an increase in the pregnancy rates. So I would strongly recommend, certainly in the case of either recurrent implantation failure or recurrent pregnancy loss, because they may be very similar type diseases, that we use tacrolimus to avoid the immune response. Shakara says, is anyone having a natural IVF? What's the cost? I called earlier, but didn't get the answer. Natural cycle IVF costs the same thing as IVF, but it does not cost for the medication. Or sometimes we can do IVF just with oral medications like letrozole or even Clomid for ovulation induction. The point of what we typically try to do with IVF is called controlled ovarian hyperstimulation. We're trying to get the ovaries to make as many eggs as we can. so that we can retrieve those eggs and fertilize those eggs because we know that all those eggs will not be normal. They will not all create normal embryos. So, in a natural cycle, we can do that without any stimulation at all. But what it means is that you will likely have one follicle. If we do some ovulation induction with a pill such as letrozole or Clomid, you might have more than one follicle, sometimes two, maybe even three, depending on your situation. But the cost of IVF is the same. And that's why most people, if they're investing in the process of in vitro fertilization, they want to try to get as many eggs as they can in order to maximize their outcomes. Well, let's see. I want to talk about one thing that's really important to me, and then we'll jump right back to questions. So if you'll forgive me for making a little aside here. When I close my program every day, I refer to this beautiful sign behind me. Those of you on this camera here in the middle see it normally, but everybody else sees it backwards because of the way the other cameras work here. This sign behind me was made by a dear friend by the name of Jody, who is now the embryologist in Sarasota at CNY Fertility. She's probably not watching tonight, but my hat goes off to Jody in Sarasota. The sign is very meaningful to me. I always say, every step forward with kindness and love and hope, and you'll hear me say this again today because every day is a new day. Tomorrow brings about a hope that we didn't have yesterday. All those things that happened today and yesterday, tomorrow are just going to be a memory. There's a new sunrise. The world is a new place tomorrow, and so we can always have hope for a new day. But it's the kindness and love part. It really seems that our world is, frankly, bereft of kindness and love on so many different levels that when you hear something that happens that is a kind and love-filled thing, that I think it's very moving. And I really feel like we should all be trying to live our lives this way so that everything that we are able to do, the little contribution that we're able to make to this world, is one that, that every interaction with someone else has the potential to change their lives. I saw on NBC Nightly News last night, there was a story about a woman a young, healthy woman with two younger children who had an incident in the hospital and unfortunately ended up losing all four of her limbs. She had to have amputations. She got septic, which means that her body was overwhelmed with infection. And when that happens, sometimes the blood supply to the small blood vessels in our periphery can be affected and can result in amputation. She lost both arms and both legs. A guy who is a builder in Florida saw this story. She's in Kentucky. He drove straight to Kentucky, gathered up a group of volunteers. I don't know exactly how they got funded, but gathered up a group of volunteers, basically built her an entire new home that was completely handicapped accessible for her, now in a wheelchair, and her two kids and her husband. Built this home in, and I believe it was 9 days, maybe 10 days. They built this entire new house. And he did this just because he was moved by the fact that something terrible had happened to someone else, and he had the capacity to make a difference in her life. And oh my heavens, what a difference in her life he made. But all the people who came together to help build that home for her, professional construction people and just volunteers alone. They all did it because they felt like it made them feel better. It made them feel better to do it. So, we don't all have to be building new homes for people because many of us don't have the wherewithal, the skill set, or the ability at all to do something like that. But it may be something so simple as smiling at a stranger, saying hello to someone who looks lonely, just a smile. Hi, how are you? Helping someone who looks like they may be lost. So I was in the airport the other day, and a lot of people looking at their ticket, looking at the monitor, trying to figure out where they're supposed to go, turned around, don't know if they're supposed to get on the train or walk down the thing. Helping someone figure out which direction to go to, letting someone get in front of you in line who is in a hurry because they're going to miss their flight. Um, um, I bought lunch for the Uber driver. I just kind of felt like the world is not it's not a friendly enough place. There's not enough kindness. And you know what? When I did that stuff, it made me feel really good. Every day that I come to work and I talk to someone and know that I can help them, I feel like I'm making a difference in someone's but more importantly, everyone that we see, everyone that we interact with, especially people we don't know, people that we do know have an expectation of us, but it's the people we don't know in whom we can really make a difference, sometimes just by a simple word, sometimes just by a touch, sometimes just by a smile. So I would like to say if there's anything that you can do this week to echo that sentiment in this world, the world really will become a better place because of what you did. So that's my 2 cents worth. Thank you for giving me that opportunity. 32 minutes past the hour. We'll be here for about another half hour. This is Fertility with Fink and Friends. I am Fink. You are Friends. And we are live from Colorado Springs as we are every Tuesday evening. Okay, Sharmila says, I'm waiting for my PGTA report. What if all are abnormal? Should I go ahead with a transfer, or what should I do since it's already my third cycle? Well, so when you have a tested abnormal embryo, or what we call an aneuploid embryo, there is still about a 5% chance that that embryo can result in a pregnancy. Remember, with PGT testing, what they're testing is they're testing the outer portion of the embryo. They're testing the portion that's going to become the placenta, not the portion that becomes the baby. So it is possible that you can have an abnormal placenta with a normal baby. And that's where that 5% number comes in. If they tested the part that's the placenta, not the baby, they got cells that looked abnormal, but it turns out really it's actually normal. Now, there are some aneuploid embryos that I would not recommend that you transfer. Because in most scenarios, an abnormal embryo simply will not implant, which means that you just won't get a positive pregnancy test. There are a lot of folks who feel like, oh, we have to do PGT because we want to have a normal baby. And I always say, of course, you want to have a normal baby. Everybody wants to have a normal baby. But an abnormal embryo typically doesn't implant, but there are some that can. And those typically go on and will miscarry, but some of them can carry on. So a trisomy 21, a Down syndrome embryo, can implant and continue to grow all the way to term, and you can have a Down syndrome baby. Now, that's not the end of the world. These are wonderful children, and if you are prepared for that, maybe that is within the expectation of what you would be okay with in life. But there are also things like trisomy 13, trisomy 18. These are chromosomal problems that are not compatible with life, but can result in a live birth. No one wants to be in the situation where they are going to have to deliver a baby that they know is going to pass away within a couple of hours. So we don't recommend that you transfer embryos that have issues with chromosome 21, chromosome 18, chromosome 13 for that reason. But can you transfer an abnormal embryo? Yes, absolutely you can. And there is about a 5% chance that that ends up with a normal pregnancy. Now, anyone who wants to transfer an embryo that is known to be aneuploid, we need them to have genetic counseling. So you have that genetic testing done from Cooper Genomics if your IVF is done here and you do PGTA. The genetic counseling is included in that cost. So all you have to do is schedule that over the telephone. You want to talk to the genetic counselor so you know exactly what the situation is. Hello to Dami1673. I like that. Let's see what else we got over here on the CNY side. R. Alvarez says, what are the odds of having an ectopic pregnancy or a miscarriage if I had my tubes removed? I have endometriosis, but I suppressed it for 3 months, did the HCG and intralipid, had one failed transfer before and some failed IUIs. So when folks tell me about unsuccessful IUI, intrauterine insemination, I don't think that that necessarily contributes to an overall pattern because IUI itself at best gives you about roughly a 9% probability of pregnancy per cycle or per month, which means that you kind of have to do an awful lot of IUIs before you get to an extremely high percentage of likelihood of pregnancy. So I wouldn't say that Ms. Alvarez is necessarily relevant there, but having had your tubes removed means that there is still a small portion of the fallopian tube, which is known as in the corner of the uterus, that's called the cornua. And if we look at my old friend, the uterus here, hi, Miss Alvarez. Okay, thank you. Sorry, I couldn't resist that. If the tubes themselves come off, well, this portion of the tube right in there, that is a little segment between the uterine cavity and where the fallopian tube begins. Again, that's called the cornua. And there is something that's called a cornual ectopic. Now, fortunately, the risk of an ectopic doing IVF with an embryo transfer is very low anyway. It's generally considered to be about 1% or less. So what are your odds? I would say your odds are extremely low, especially since the majority of the fallopian tubes have been removed. So I think you're in okay shape there. Let's see. Bryn says, I am 5 weeks and 2 days today. I didn't see much on the ultrasound. The beta was 1,095. So the reason we do the beta HCG is to know when that level is at about 1,500. By the time you are at an HCG level of 1,500, we should expect to definitively be able to diagnose that the pregnancy is in the uterus. My guess is that's probably, my guess is they may have been able to see that today. Usually it would be a sac that's inside the uterus that's called a gestational sac. Then it's usually by a little after 6 weeks that we should expect to be able to see the heartbeat. So when you first see the heartbeat, that heartbeat may be a little low because as it first begins, it may start around 90 or 100 beats per minute. By the time you're about 6.5 weeks, it's usually between 120 and 140 beats. We like to see that normal rate in the heart rate because if the heart rate is low, that can suggest sometimes an issue with pregnancy. So I think I'm almost certain, Bryn, if you repeated your ultrasound a week from today, you'll be able to see everything that you need. So congratulations there. Hi to Breaking Path and Sydney Sweeney. Caitlin 10 says, is there anything I can do if I have one blocked fallopian tube? Well, Caitlin, if you have one blocked fallopian tube, it means that your fertility is really about the same as it would be if you had two functioning tubes. So one working tube really is not a deal breaker at all. I would say it's worth, a consultation to talk about what are some of the other things that we can do, some of the less invasive, easier things to do to kind of help get sperm together with egg, but one fallopian tube is not a deal breaker. So good deal there. Let's see. I know we got some questions here. Can ovaries recover from surgical removal of big endometriomas? Ovaries do not regenerate. Surgical removal of a 5 centimeter endometrioma typically does not result in earlier menopause, because even if you take one ovary and completely remove it, having one functioning ovary means that your hormone levels, that your time to menopause is really essentially the same as somebody who had two ovaries there. Now, if we take one ovary out, oftentimes the AMH level, which is, of course, the anti-Mullerian hormone, the test of ovarian reserve, that number will go down. And if you have a surgery to remove that portion, the cyst in the ovary there, that will also lower the AMH. So unfortunately, no, ovaries don't regenerate, but when you remove a cyst, you're actually only probably going to be removing, believe it or not, a small portion of the ovary. Now, in general, for folks who are doing IVF, who have endometriosis collections in the ovary, I usually recommend that you get your eggs first. So do your egg retrieval. Worry about getting that out afterwards, because in most cases, it's not going to stop us from being able to retrieve eggs. Most cases. Does a high first beta mean an embryo split? Not necessarily, no. So you would think that, okay, well, if I'm expecting a number of about, 50 to 75, if that number comes back at 150, does that mean that I have two embryos in there secreting hormones? Nope, not necessarily. It just kind of depends on how the embryo implanted, when exactly it implanted, and what else is going on there. By the way, if we want to compare what a urine pregnancy test hormone level is to what a blood test is, most urine pregnancy tests will now pick up a hormone level that's about a 35 or maybe a little bit less than that. They're not all that sensitive, but if you say I had a positive urine pregnancy test, I'm going to think, okay, that beta is probably at least kind of a 35 to 50 sort of range. A special hello to Zeneda in Miami. Hello, Miss Zenny. Nice to see you here this afternoon. Noodles for Life says, last medicated FET, I ovulated through estrase. This time they added Lupron, but my estrogen is over 2,000. Is high estrogen a concern for an FET? Well, if it gets really high, like if it's above 3,500 to 4,000, we start thinking, well, that sometimes means that the lining may not be hospitable. But adding Lupron to stop the ovulation is a perfectly reasonable thing. And I think, Noodles, you're going to be okay there. Back on the Instagram, Facebook side, Alicia asks, said, tomorrow I am 8 weeks pregnant with twins from my August transfer. Awesome. I completely think that the increase in Prograf helped with my autoimmune issues, which helped after my 5th successful transfer. Congratulations, Alicia. God, that is fabulous. Boy, I love that. Ferdoz asks, can you clarify what is Prograf? Prograf is a medication. Tacrolimus is the generic, and that is one of the medications that we use in our autoimmune profile. And personally, I believe everyone should be on Prograf. It's a safe medication to take during pregnancy, or at least in the first trimester. There's no reason to stay on it later on for most people, but it was studied with recurrent implantation failure and recurrent pregnancy loss. My feeling is, well, it's a cheap medicine. It's generic. It's safe. It's easy to use. It has really relatively few side effects. So I would rather avoid you having to get into the position of having recurrent pregnancy loss or recurrent implantation failure. So I'd rather you use it up front, just preemptively. Hopefully that is helpful there. Kristen says, fresh transfer failed at the end of August. We're doing an FET, frozen embryo transfer, on Monday. transferring a 4AA and a 4BB. So a frozen transfer is always going to be more successful than a fresh transfer. That particularly becomes true as we mature. So a fresh transfer will be most effective for women in their 20s, a little less so in our 30s, and significantly less so in our 40s. Frozen transfer means that the body's had a chance to recover. When you're doing a fresh transfer, your body's been in egg making mode. And when you're in egg making mode, that may kind of keep you separate and apart from being in pregnancy mode. And that's the reason. Can your embryo grade change when they thaw? Yes, they can. So when we thaw an embryo, we will see that embryo starts to expand again, and sometimes it will start to hatch. The embryo can start to compact and look better. So yes, embryo grades can change, but we don't specifically, really look at that or regrade embryos because there's really no reason to. The grade does not specifically correlate with outcomes. So Gina Davis is here. I am excited to start next month, and we are excited for you. Carolyn asks, can an embryo transfer date be determined by the start of my period? Can I change the FET date by being given meds to change my period start date? Well, so the date can be, if you're doing a medicated cycle, then the only thing that's going to be fixed for you there, Carolyn, is that you're going to get 6.5 days of progesterone. So if we need to make your embryo transfer on a certain day, from the time your period starts, the amount of estrogen you get in the beginning can be quite variable. So we used to think in a medicated transfer that you had to get 14 days of estrogen so that it was mimicking what would happen in a natural cycle. What we know now is that's really not necessary, that, as few as 5 or even 6 days of estrogen can be enough to make the lining thick enough and hormonally receptive so that then when we start the progesterone, 6.5 days or 120 hours of progesterone is what you need before that embryo transfer. So yes, if you're doing a medicated cycle, we do have the ability to kind of have some degree of control over those logistics. Katie asks, should you donate plasma if you're planning on doing an IVF in the next 6 months? I can't find a lot of information. I don't think it matters. I don't think you will see a lot of information about that, Katie, if you're a plasma donor. I don't believe there should be any real effect on your ability to respond. Now, if you're donating and then you're going to be, really fatigued and stuff, maybe you don't want to kind of jump right into an IVF cycle. Maybe you want to give that a little bit of a break first, but I think that would be okay. Hi to Lindsay. Thank you for being here today. Alicia asks, what's the best FET protocol for someone with Asherman syndrome and a stubbornly thin lining? Asherman syndrome is when you develop scar tissue in the uterine lining. Now, there are some people whose linings do not grow very thick or very well when we give them the estrogen that we use for a medicated cycle. And so when I see someone is doing a medicated cycle and the lining is not growing, first thing I look at is, well, what would happen if we did a natural cycle? Because it may be that your lining is doubly thick when your own hormones are doing the job instead of when we're trying to give you the estrogen from the outside. So that's something that I really want to know. We can also do so it's hard to say there, Alicia, whether it's a medicated cycle or a natural or modified natural. For you, kind of depends on the history, but there are some other things that we can do for endometriums that don't want to grow. There's an injectable form of estrogen that's called delestrogen. Sometimes that will work when the oral or vaginal estrogen doesn't. We can do vaginal Viagra, which increases the blood flow to the uterine lining. This actually reminds me of another quick question somebody asked me. So, and that had to, well, I'll get to that in just a second. It has to do with Viagra and libido sex drive for women. We'll talk about that in just a sec. What else can we do for that lining? We can also, intrauterine PRP, platelet-rich plasma, is really wonderful, both for treating recurrent scar tissue and for helping that lining to build. So those are the first kind of things that I think about, Alicia. I got a question emailed to me, and it was a hormone question in general, and it had to do with sex drive. What can I do to improve my libido? My husband is always chasing me around the house, and I am just sometimes not into it. That was the question, and I think that is a very common question. Male libido and female libido tend to be very different things. And tend to be initiated by both different hormonal stimulation and by different intellectual stimulation. So I could have a whole lecture on this. In fact, we did a talk once on human sexuality, and surprisingly, a lot of people didn't. I was one of my least well watched Fink and Friends. But the question was, can I use Viagra? Viagra does increase the blood flow to the genitals. And that may be even more so in the case when you are aroused or trying to get that way. However, the studies showed that Viagra was really not useful in increasing libido. So genital blood flow increased, and they had a special instrument, a special vaginometer that would measure the blood flow that was going to the clitoris and to the vagina. Blood flow did increase as a result of taking Viagra. However, the women who were these study subjects didn't actually recognize that they felt anything different, which suggests that the stimulus for libido is not one of the physicality like it is for a male. If the male takes Viagra and stimulates himself, or is stimulated, obviously you can see what happens there. That tissue becomes engorged, and there is his libido. In a woman, the libido starts here. The biggest sex organ in the female body is in the brain. And so while Viagra has an effect on increasing blood flow to the clitoris and to the vagina, it does not have an effect on increasing blood flow in the brain. And so it really didn't do anything for libido. Now, it did do something for orgasmic inhibition, and that is those who are unable to achieve, women who are unable to achieve an orgasm. So the blood flow has something to do with orgasm, but less so to do with sex drive. Hopefully that answer helped. And if not, well, at least maybe you found that interesting. Novak Ashley, hello. Can you do a frozen embryo transfer the next cycle after a hysteroscopy? The answer is absolutely yes. Yes, you can. A special hello to the Castle family for being here. Thank you. If you're still on, we're about 7 minutes to the top of the hour. Let's see. I flew. We were talking earlier about travel. JM Dot said I flew for a cycle monitoring in 2021 and was late for my appointment by over 4 hours. I could have driven to Toronto instead. Don't want to fly for IVF. I don't blame you at all. It's very difficult to kind of feel confident in timing schedules when you're flying. So if you're traveling for care to CNY or any place else, make sure that you give yourself a buffer to be there. Manda May. Okay, I get it. I used Texas for fertility, so I had one doctor. Well, I have one doctor with CNY. The answer is no. You will not. You will see. Well, it depends on kind of where you go. So if you come here to Colorado Springs, I'm the doctor here. I have my wonderful nurse practitioner, Brandis, who is here. So you will interact with both of us. If you go to our Buffalo facility, Dr. Chang is the only doctor in that facility, but at Syracuse, at Albany, and in Sarasota. There are multiple physicians who are doing procedures. And when you call for an appointment, you may have an appointment with a different person than who you will be seeing for your treatment. If you have a preference there, let's say, hey, I'm going to be going to Colorado. I want to talk to one of the Colorado providers. Just ask us at the call center, and they'll try to make that happen. Or you're going to Albany, you want to talk with Dr. Grossman or Dr. Didkoff, then absolutely, you just say so. Um, Let's see. Lovely Onyx says, I'm 23 weeks pregnant and I don't feel my baby move all the time. Is this normal at this point? Yeah, absolutely it is. So we usually start feeling fetal movement around 20 weeks of pregnancy. But remember, the baby is really pretty small at that point, and so you won't feel movement all the time. Now, by the same token, even when you're a week from your due date, you're not going to feel the baby moving all the time. And why not? Because they spend a lot of time sleeping. They go through sleep cycles just like they do after they're born. Now, one of the things that can also have an effect on how much you feel your baby moving is where the placenta is located. So let's say that the uterus kind of looks something like, well, I mean, really, it looks like this, right? And it's sitting here in your belly, like so. If the placenta is on the top, which is what we call an anterior placenta, the placenta is on the top part of the uterus, then the placenta, which is a big, thick, blood-filled organ, is sitting between the baby, the amniotic fluid, the uterine wall, the abdominal fat, and everything else that's there between you and the baby. So you got a bunch of stuff that's sitting there. An anterior placenta often decreases how you feel fetal movement. So the other question I would ask there, Onyx, is well, I wonder where your placenta is. But at 23 weeks, nope, you would still kind of just be maybe even still feeling the butterflies more so than something flipping over and kicking you and stomping on your bladder and all those things that you can come to expect as time goes on. Elisita says, thank you for being so informative. My pleasure. Once a heartbeat is detected, what are the risks of miscarriage? What should progesterone be for twins? So once we see the heartbeat, again, 95% of those pregnancies continue on without a problem, which means there's about a 5% miscarriage risk up through about 12 weeks of pregnancy. And that's the first trimester. Once you are out of the first trimester, then that risk drops down to about 1%. Let's see here. On the CNY side, how many months after stopping Orilissa should your period return? Usually in that next cycle. Now, if you're going to do something like an embryo transfer, and I do recommend you do a transfer in the very month after stopping your Orilissa, that you go directly from endometriosis suppression into your embryo transfer cycle. Things can be sluggish just because you've had the volume knob turned down from that medication. But usually within a month or certainly no more than 2, your period should return. Is it normal not to see anything at 5 weeks and 2 days on ultrasound? Yes. Yeah. My beta was 1095. So again, the number I'm looking for there is 1500. By 1500, you should definitively be able to say that pregnancy is inside the uterus. Lexi Graham says, my wife has one left ovary. Can she do IVF? Absolutely. There are some people who have 2 ovaries, but maybe one side doesn't have a great blood supply for whatever reason. I always say, you're left ovaried, aren't you? So some people may have, 15 follicles in one ovary and no follicles on the other side. That's a very common finding. So if you've had one ovary removed for some reason, absolutely, you are still a candidate for, and maybe even a better candidate for IVF. Liz K. Nader says, my baby girl is 6 weeks old and born at 35 weeks. Thank you for my beautiful blessing, Colorado Springs. Liz, God, we love to hear that. Thank you so very, very much. Let's see. Oh, my Glinda says, I am 34, first time doing IVF. Do you allow 2 embryos to transfer? So we follow the guidelines of the American Society for Reproductive Medicine, and that would say that we recommend that you transfer 1 embryo on your first embryo transfer. However, if you wanted to transfer 2, as long as you understand the risks of doing so, we will not forbid you from doing it. What are the risks? Well, it does not increase the risk of a live birth. It actually increases the risk of pregnancy loss, NICU stays, and all kinds of other bad things. So generally, we don't recommend it. But will we do it for you if that's what you want? Yes, we will. Now, if you said, "Hey, I'm 34 and I want to transfer 3 blasts," will you do that? No, we won't, because we absolutely positively cannot get you triplets. We don't want that to happen. If you had twins, again, that's not what we want. We want 1 healthy baby at a time. So let's see. I wanted to know, Levine says, is it safe to put in multiple embryos for a person doing first-time IVF, fresh transfer? So kind of same question there. Michelle says, I finally have my consult on Friday. I wanted to ask, as someone that has PCOS, what IVF is typically recommended? Will a fresh transfer be an option in the possibility of developing hyperstimulation? Yes, with polycystic ovarian syndrome, we have a higher risk for developing ovarian hyperstimulation. And as a result of the hormonal changes associated with making a lot of eggs, which happens with PCOS, typically a fresh transfer is not a good idea. There may be some scenarios where we will tell you absolutely not, no way. But in general, I would say if you're prone to PCOS, I would 100% not suggest a fresh transfer, because the odds of its success drops way down. So what would we do in that scenario? Well, we will lower your dose of medication, because we don't want you to be hyperstimulated. We don't need you to make 80 eggs, because anything more than about 15 probably does not improve the outcome. So that's kind of the way we approach that. Hey, folks, gosh, top of the hour, and it has flown by, as it always does. I sure am honored that you would take your evening and spend a little time with me and the rest of your friends here on Fink and Friends. So until next week, as always, it's that one little act of kindness. Please do something this week. Make it a point to do some random act of kindness to someone who isn't expecting it. And maybe next week we'll talk about it. Tell me how it made you feel. Every step forward with love and with hope. Tomorrow is a new day, and whatever happened before is really just a memory. It's a construct of our brain, our imagination. Tomorrow brings about all new things. This fertility business is not the book of your life. It is just a chapter. And what are we doing? We are here together to help rewrite it. So until next week, I'm Dr. Randy Fink, live from Colorado Springs at CNY Fertility. Thanks for being here. Good night.